Your patient's right pupil is blown, fixed, and dilated. The left pupil is normal. You have minutes to act before the brain ignites and they die. This is not a drill. This is increased intracranial pressure (ICP), and it's one of the most time sensitive emergencies in nursing. Hi, I'm Tochi. I'm a nursing student, senior nursing student, preparing for my critical care exam. And today we're talking about nervous system alterations, part one, specifically increased intracranial pressure, also known as ICP. What is it? Why it happens? And what do you do when you see it? In the next 30 minutes, I'm going to teach you what ICP actually means and why it's deadly, the signs you should catch early, how to calculate cerebral perfusion pressure, also known as CPP, nursing intervention that saves life, when to call for help. No medical jargon, no boring lectures, just clear, simple explanation that will help you understand the brain emergencies you see in ICU. You ready? Let's go. Okay, let's start with the basic. What is intracranial pressure, you say? Well, inside your skull, you have three things. One, brain tissue, about 80% of the space. Two, blood, about 10%. And three, cerebrospinal fluid, CSF, about 10%. That's complete 100%. So your skull is a fixed space. It's rigid. It can't expand. So when one of these three things increases, the others have to decrease to keep the pressure normal. They have to compensate so that everything still stays and function the way it has to. Now, this is called Monro-Kellie doctrine. Think of your skull like a full water bottle. If you add more water, something has to come out of the bottle or it will burst. Same with your brain. Normal ICP, 0 to 15 mmHg, but some sources say 7 to 15 mmHg. Elevated ICP is anything above 20 mmHg. And when someone is like elevated, it's a problem, but it's manageable. But when they're in the critical intracranial pressure increased, it's about 30 mmHg. So when your ICP goes up and stays up, blood flow to the brain decreases. This causes ischemia brain tissue. And ischemia brain tissue is basically your brain tissues are not getting the oxygen they need to properly function. So they don't get the oxygen and then the brain cells start to die. We have about 6 minutes for no oxygen to go to our brain and then they start dying, and when they start dying it's a problem. So if so if the pressure gets high enough, the brain will start to herniate, and that meaning that the brain tissue gets pushed through openings in the skull or down into the spinal cord. It's gonna try to, like water, when water is leaking, it tries to find way to get out. That's what the brain is going to do. It's going to start going into it's going to start going to push through openings the skull or down into the spinal canal. Basically what I'm saying is herniation is death. That is why this is critical. So what causes increased ICP? Well, the three causes. Remember those three components I said? The brain tissue, which is 80%, the blood, which is 10%, and the cerebrospinal fluid, which is 10%. Let's talk about what makes each one of them increase. Number one, increased brain tissue, cerebral edema. This is the swelling of the brain. There are two types. There is this cytotoxic edema, which is basically swelling inside the brain cells. It's caused by hypoxia, low sodium, that's hyponatremia, stroke. Think the cells are waterlogged, like they're really, think of a sponge where it's like really soaked of water, like it has really absorbed so many water, and it's like, you know how it feels. That's how the brain cells are now. And then we have vasogenic edema. The fluid is leaking out of the blood vessels into brain tissue. This is caused by tumors, infection like meningitis, and traumatic brain injury. Think the blood brain barrier is broken. Number two is increased blood volume. Normally, the blood vessels in the brain, they can constrict or dilate to regulate the blood flow. This is called autoregulation. Our body is amazing like that. But when autoregulation fails from hypoxia, hypoxia is low oxygen. Then ICO2 is high carbon dioxide, or trauma blood vessels dilate and more blood flows to the brain. Let's repeat that. So normally the blood vessels in the brain, they can constrict or dilate to regulate blood flow. This is called autoregulation. But when autoregulation fails from hypoxia, which is low oxygen, high carbon dioxide, or trauma blood vessels, they dilate, they open wider, they open like a big hose, and more blood flows into the brain. When there's more blood, there's higher pressure. More blood, higher pressure. So what causes this? Low oxygen, PaO2 less than 60. Now our normal PaO2 is 80 to 100. So when you're having less than 60, that's critical. That's not good. That's like, we don't want to get there. Another one that causes it is high CO2, that's high carbon dioxide, when your PaCO2 is greater than 45. Remember, our normal for PaCO2 is 35 to 45. So, greater than 45, not good. And then high blood pressure, and then head positioning, like if the head is turned to the side, it compresses the vein. Number three, increased cerebrospinal fluid. This is called hydrocephalus, literally water on the brain. I thought of that song, Love on the Brain, but no, this is not Love on the Brain. This is Water on the Brain. So, cerebrospinal fluid is produced in the ventricles and normally drains into the bloodstream. But if there's a blockage, tumor, blood clot, infection, the cerebrospinal fluid backs up and pressure rises. Let's pick this again. So, number three cause is increased CSF. It's called hydrocephalus, which is water on the brain. CSF is produced in the ventricles and normally drains into the bloodstream. But if there's a blockage, a tumor, blood clot, infection, the CHF backs up and pressure rises. Now, so to recap, brain swelling, also known as edema, it leads to increased intracranial pressure, increased ICP. More blood in the brain, increased intracranial pressure. Cerebrospinal fluid backed up causes hydrocephalus, water on the brain, not love on the brain. Which then causes increased intracranial pressure. Now let's talk about what this look like in your patient. Okay, this is critical. You need to recognize increased ICP early. Early signs: number one, change in level of consciousness, the most sensitive indicator. Our brain is always like very, very sensitive. Patient becomes confused, drowsy, restless. They take longer to respond to questions. They Gaslow their GCS glass glow coma score starts dropping. Our normal GCS is 15. So if your patient was alert an hour ago and now they're lethargic, like, what caused the sudden lethargicness? Well, that's a red flag. You need to assess immediately. Number two, if they have headache, severe persistent headache is worse in the morning or when laying flat, doesn't respond to pain meds, even though you give like opioid, it's not working for that headache. Nausea and vomiting, when they projectile vomiting is sudden, forceful, and then literally the name it projects. It's like shoot like a dart. Pew, pew. Especially in the morning, blood vision or diplopa, that's when they have diplopa is another word for double vision. So basically they have pressure on optic nerve. Late signs, say early signs, you have to catch it early, you have to do your nursing intervention, you have to help treat it. But you see, when we get to late signs, this is bad. Cushing Triad. That's number 5. Cushing Triad. This is a late sign. If you see this, your patient is in serious trouble. 3 components of Cushing Triad: hypertension. They have high blood pressure with widening pulse pressure. So when I say widening pulse pressure, so maybe your patient's blood pressure was, it's their normal. The normal baseline is 120 over 80, and then all of a sudden they are 130 over 60. Not good. Bradycardia, slow heart rate. Their heart rate is slowing down. They have irregular respirations like chain smoke breathing. I can't describe how that breathing is, but chain strokes breathing. And then apnea. Apnea is like kind of like a snoring sound. Why does this happen? The brain is being compressed. It tries to force more blood through increasing the blood pressure. The body responds with bradycardia to slow things down. So your body is actually, it's trying to keep you help you and to fight this. That's how amazing our brain is. It's going to go into survival mode, it's going to go into warrior mode, it's going to go into fighting mode to try to do stuff. But if you see Cushing Triad, your patient is about to herniate, call for help immediately. This is an emergency. Now, number 6, pupil changes. This is when they have like sluggish or absent response to light, unequal pupil when you use your light, your pen light. It's unequal pupil is called anisocoria. One pupil is blown, that is, it's fixed and then it's dilated. Like, it's like, before your eyes dilate eyes open, it has a bright light has to literally shine into it for it to dilate. Right now my eyes is constricted because it's as I've just said to the lighting. But yes, so when it's fixed and dilated, the pupil it's blown. Okay, if the right pupil is blown, there's a lesion on the right side pushing the oculomotor nerve. Now, this is a late sign. The brain is herniating. Number 7, posturing. Decollete posturing. This is when the arms are flexed towards the chest and like a mummy, and the legs are extended extended, and then it indicates damage above the brainstem. Now, decebrate posturing is the arms are extended and rotated inwardly like this. For the decotates, the arms are flexed and like this. And then this one is like this. The decebrate positioning is extended and rotated inwards. Legs are extended. Decebrate is worse than decotate posturing. It indicates the brainstem itself is damaged. God forbid. So if you see posturing, your patient is critically ill. This means the brain is herniating. Okay, now let's talk how we can monitor the ICP. Now, in the ICU, we monitor ICP directly using an ICP monitor, usually a ventriculostomy. This is a catheter inserted into the ventricles of the brain. It measures the pressure and it can drain cerebral spinal fluid if needed. Normal, remember, as we said this earlier, normal ICP is 0 to 15 mmHg. Other sources claim 7 to 15, but we're going to be sticking with 0 to 15. Elevated is 20 above 20 mmHg. Critical is 30 mmHg. Now, but ICP alone doesn't tell the whole story. We need to know, is the brain getting enough blood? This is where CPP comes in, that's cerebral perfusion pressure. So CPP is equals to MAP. Remember, our MAP is the mean arterial pressure from your blood pressure. So MAP minus ICP. That's how you get your CCP. Remember, MAP mean arterial pressure, ICP is intracranial pressure. So your cerebral perfusion pressure is MAP mean arterial pressure taken away from intracranial subtracted intracranial pressure. Now let's say I'm going to give you an example. Let's say MAP is 80 mmHg, and then ICP is 18 mmHg. CPP, your cerebral perfusion pressure, is 80 take away 18, and what are we left with? 62 mmHg. Now, our goal CPP, cerebral perfusion pressure, is at least 60 to 70 mmHg. If a CCP drops below 50 to 60, the brain isn't getting enough blood, then the brain tissue becomes ischemic, no oxygen. So your job as a nurse is to monitor the intracranial pressure, ICP, monitor your blood pressure, calculate the cerebral perfusion pressure, CPP, report if CPP drops below 60. Now, let's talk about what you do to manage and increase intracranial pressure. All right, your patient has increased ICP. What do you do? Well, number one, in first intervention is positioning. Head of bed elevated 30-degree. Why? Because gravity helps drain the cerebral spinal fluid and venous blood away from the brain. Now, if your head is in a neutral position, not turned to the side, turning the head compresses jugular veins and blocks uh the venous pressure. So yeah, I feel like we should understand that. So when you turn the patient, turn them log log row style, because entire that's like basically get help. Someone should help you, so the entire body goes together, so the head still stays neutral. Now, suctioning increases pressure. Only suction when absolutely necessary. Pre-oxygenate first and then limit to 10 seconds. You go in, you don't suction, then when you're coming out, you slowly pull it out while suctioning. Coughing, straining, Valsalvia maneuver. It's like give to softness to prevent straining. So our first intervention was position. Our second intervention is to avoid things that increase the ICP, like suctioning, coughing, straining, hip flexion. You want to put pressure on abdomen. Um, Hip flexion puts pressure on abdomen, which therefore increases intracranial pressure. So you don't want to bend your knees too much. You want to leave it as straight as possible. Clustering care. Space out activities. Don't do everything at once. So, uh, So you know how we like to do cluster care. We want to, like, when we go into the room, want to do everything at once. That is good in some instances, but for this situation, we want to space out our care for this patient. Our third intervention is to maintain oxygenation. Basically, our goal is for the PaO2 to be greater than 80 mmHg. So when there's low oxygen, it causes blood vessels to dilate. Then there's more blood volume. When there's more blood volume, there's higher intracranial pressure. But we want to keep the oxygen saturation about above 92 to 95%. Now, our fourth intervention is to control CO2. Our goal for this patient will be to make our PaCO2 within the normal limit, 35 to 45, nothing above, nothing below, because high CO2 causes vasodilation, which then increases blood flow, then increases ICP. But low CO2 will cause vasoconstriction, decrease blood flow, which then causes ischemia of the brain, and then, as we've discussed. So we want the CO2 in the normal range. It can be below, it can be above. It's going to cause too much pressure, which should then increase the ICP, or below, it's going to decrease blood flow and then cause ischemia and then lead to death of the brain tissue, which then leads to like all of that stuff. We don't want that. So we keep it in the normal range. So if a patient is on ventilator, we want to monitor closely. Now, we want to keep the patient evolemic. So, not too dry, not too fluid overload. We want basically everything regarding ICP patients, we want to keep them balanced. Like, they can go a little bit this way, a little bit that way. No, we want to keep them balanced, not too dry, not too fluid overload. So basically, we're going to be using only isotonic fluids. Do you know your isotonic fluids? Well, isotonic fluids are like what we have inside our body, inside our cells. So isotonic fluids like normal saline, lactated ringers, normal saline, 0.9% normal saline. 3% normal saline is hypertonic, and then 0.45% normal saline is hypotonic. So 0.9% normal saline and lactated ringers. We want to avoid hypotonic fluids like D5W, 0.45% normal saline, because they can worsen the cerebral edema. Now, we want to monitor intake and output very strictly. We want the serum osmolarity to be less than 320 ml. Like, we want it to be less than 320. We want to do daily weights to know if they are getting fluid overload or they're getting dehydrated. So intervention 6, we want blood pressure management. That's very important because we want our goal to be a map of 70 to 90 mmHg to maintain the CC, to maintain CPP above 60 to 70. Basically what I'm saying, we want our mean arterial pressure from taking the blood pressure to be 70 to 90 mmHg to maintain cerebral perfusion pressure above 60 to 70. Now, we don't want the blood pressure too low because if it's too low, there's not enough blood flow going to the brain, and then this causes ischemia. And we don't want it too high because too high causes vasodilation, which then increases ICP. So if blood pressure drops like below a certain like level, we want to give vasopressors. And if blood pressure spikes, goes up, we want to give antihypertensive very carefully. Remember, these medications have side effects. Now, our seventh intervention is temperature control. Now, fever increases metabolic demand, and then the brain needs. Okay, let's explain. Fever. Fever increases the metabolic demand, which then makes the brain need more oxygen. And then if the brain is getting more oxygen, it needs more blood flow. And then when there's more blood flow, there's higher ICP. Now, you want to treat fever aggressively with acetaminophen, with cooling blanket, and sometimes induce hypothermia, but we want to make sure we're between 34 to 35 degrees Celsius. Our eighth intervention is to implement seizure precautions. Seizure increase metabolic demand and intracranial pressure. You want to keep suction and airway equipment at bedside to wave bad energy, wave bad. We don't want anything happening to this patient. We also want to beat them on prophylactic anticonvulsants. It may be ordered. Those are your nursing intervention. Now let's talk about medical treatment. Medical management of increased ICP focuses on reducing pressure quickly. So our first treatment is osmotic diuretics, that's Mannitol. It pulls fluid out of the brain tissue into the bloodstream. We want to give it IV blowers. It works fast within 15 to 30 minutes. That's our amazing Mannitol. But be careful because this medication is one of those medications that crystallizes. And we want to monitor for dehydration and electrolyte imbalance because side effects. Now, hypertonic saline, that is a 3% or 23.4%. This creates osmotic gradient to pull fluid out, and it may be effective, it may be more effective than Mannitol in some cases. You want to be treating patient centered, focused. Now, your second treatment is diuretics. Now, when I say the first one was osmotic diuretics, the second treatment is diuretics. This is where we have furosemide, that's your Lasix. It's a loop diuretic. It will reduce the cerebrospinal fluid production and is often given with Mannitol. It goes alongside with Mannitol. So basically, you want to be watching for hypokalemia. That's the low potassium. And we also be monitoring for dehydration because this medication pulls the fluid out and it makes them pee a lot. So now, treatment 3 is sedation. When I say sedation, that's we're talking about propofol, we're talking about benzodiazepine like Ativan, we're talking about decreasing, and this medication, the sedative, is going to help to decrease metabolic demand and reduce intracranial pressure. Now, treatment 4 is analgesia. Analgesia basically is pain meds. Now, pain increases intracranial pressure. It keeps patients comfort. Pain increases intracranial pressure. Analgesia, analgesic pain meds is going to keep the patient comfortable. We always want our patient comfortable. Now, we have fentanyl or morphine. We want to titrate carefully. We have treatment 5, which is ventricular drain. If a patient has ventriculostomy, the cerebral spinal fluid can be drained and to immediately reduce pressure. Now, our treatment 6 is hyperventilation, which is used cautiously. In emergencies, we can temporarily hyperventilate the patient to lower CO2. Now, when there's a low CO2, we have vasoconstriction, which then leads to less blood flow, which then help lower the intracranial pressure. But I knew there was a but coming. But this is only temporary and can cause ischemia, which is when the oxygen does not go to the brain and then it starts dying. Basically, we use hyperventilation as a bridge until other treatments work. Treatment 7, surgery. If there's a hematoma, if there's a tumor, if there's severe swelling, craniotomy. Craniotomy is when they remove the bone flap to allow the brain to swell. Like basically they will cut out a section of the brain to give of the not the brain of the skull to let the brain be able to swell. And also hematoma, it helps with hematoma evacuation. That means to be able to properly drain. Bottom line, increase ICP, increase intracranial pressure is a team effort. You're monitoring, you're intervening, and you're communicating with the medical team constantly. Now, real quick, let's touch on 2 other neuro emergencies. We have the stroke. Stroke is a brain attack. There are 2 types. There's the ischemic, which is 85%. That's how common. 85% of stroke that happens is ischemic stroke. Basically, the clot blocks blood flow to the brain. Treatment is TPA. It's a clot buster within 4.4 to 4 hours, 30 minutes. 4.5 hours, because time is brain. Every minute counts, because for every minute that the brain is not getting oxygen, it's for every minute is slowly dying. So every minute counts, time is brain. And then there's hemorrhagic. 15% of stroke that happens is hemorrhagic. Basically means bleeding in the brain. The treatment will be to control blood pressure, surgery if needed, and hemorrhagic stroke can cause increased intracranial pressure. Now, signs of stroke. Remember FAST, FAST. F is face drooping. A is arm weakness. S is pitch difficulty. T is time to call 911. Now we also have traumatic brain injury. Traumatic brain injury is caused by falls, motor vehicle accidents, assault, sports injuries. Now there are types of traumatic brain injury. There's concussion. Concussion is mild, it's temporary. There's contusion, which is the bruising of the brain. There's hematoma, which is epidural, that's bleeding between the skull and the dura lens shape on CT. Then there's subdural, which is the bleeding between the dura and the brain crescent shape. And then there's intracerebral, which is the bleeding inside the brain tissue. Traumatic brain injury causes increased ICP, increased intracranial pressure. Management is the same. You want to monitor, position them, you want to control their blood pressure, you want to give osmotic diuretics, and you want to prepare for surgery. Now, both stroke and traumatic brain injury can lead to intracranial pressure, which is why understanding ICP management is so important. All right, let's wrap this up. Here's what you need to remember. One, ICP is pressure inside the skull. Normal is 0 to 15 mmHg. Elevated is 20. Critical is above. Elevated is above 20. Critical is above 30. Number two, Monro-Kellie doctrine. Brain 80%, blood 10%, cerebral spinal fluid 10%. If one increases, others must decrease. So if you know the math, if one increases, others must decrease. Now, three, early signs change in level of consciousness, headache, nausea. Catch this. You want to catch this. Number four, late signs, Cushing triad, blown pupil, posturing. This is an emergency. Number five, cerebral perfusion pressure is equals to mean arterial pressure take away intracranial pressure. We want our goal for our cerebral perfusion pressure to be 60 to 70 mmHg. Now, number six, our nursing intervention. We want to elevate head of bed 30-degree. We want to keep their head neutral. We want to do log roll to keep their head neutral. We want to maintain oxygenation and normal CO2 oxygenation of above 92 to 95%. We want normal CO2 35 to 45. We want to avoid clustering care. We want to space out our care with this patient. These are the special ones where we do not need to cluster our care. We want to monitor vitals carefully and very closely. Number seven, medical treatment, Mannitol, Hypertonic, Saline. We have diuretics like laxes, sedation, surgery if needed. And that's, my dears, is increased intracranial pressure simplified. If this helped you, please hit that subscribe button. I am posting nursing videos every week. Next week we'll be covering part 2 of the Neuro of the brain. So drop your question in the comments. What part of neuro nursing is still confusing? You are doing amazing. Critical care is tough, but you are learning. Well, I think other people do it as med-surg. Critical care med-surg is tough, but you are learning, you're preparing, and you're going to save lives. See you next time. Keep studying, stay focused, and remember, you got this. Bye.